Hello everyone, this is Dr. Meghna and welcome back to my channel. I'll be discussing the important aspects of fibrous dysplasia, including the etiology, pathophysiology, clinical features, radiologic features, histological features, diagnosis, and treatment. This video will be of great help to give your university exams, so try not to skip the video. Coming to the definition, fibrous dysplasia. It is a skeletal developmental anomaly of bone forming mesenchyme that manifests as defect in osteoblast differentiation and maturation. Its etiology is usually due to genetic mutation in GNAS1 gene. It is present on chromosome number 20 long arm. This encodes for G protein. This protein plays a crucial role in cell signaling, particularly in the production of cyclic AMP. You can see this image. The rectangular box is the G protein. It has three subunits, the alpha, beta, and gamma. In inactive state, all the three subunits coexist. While in active state, GTP binds to alpha subunit and cleaves it from the remaining beta and gamma subunits. This leads to conversion of adenyl cyclase to cyclic AMP. Cyclic AMP activates the protein kinase A and phosphorylates the target proteins, altering their activity and ultimately affecting various cellular processes. The process slows down as the GTP gets exhausted and is removed by the GTPase enzyme. In fibrous dysplasia, GTPase enzyme is defective due to GNAS1 gene mutation. So, GTP continues to activate the alpha subunit of G protein, and cyclic AMP increases continuously, leading to overactivity of various target cells. As you see in this flowchart, the three main systems are affected in fibrous dysplasia. First is the endocrine glands, whose overactivity leads to precocious puberty if the ovaries are affected, hyperthyroidism as the thyroid glands are affected, hyperparathyroidism as the parathyroid glands are affected, Cushing's disease as the adrenal glands are affected. There is also growth hormone and cortisol overproduction. This affects various metabolic processes. Second is the overactivity of melanocyte, which leads to melanin overproduction. And this causes coffee brown spots on the body called cafe au lait pigmentation. Third is the most important, which is the osteoblast. In fibrous dysplasia, osteoblastic maturation or differentiation is affected. The immature osteoblasts proliferate and increase production of immature bone. Medullary bone is replaced by fibrous tissue which undergoes osseous metaplasia to form abnormal and irregular cancellous bone. You can see the CBCT of skull which shows a distinct lesion on the left maxilla. Coming to the different types of fibrous dysplasia, it's classified into three main types. Let's see one by one in detail. First is the monoosteotic form. Mono means one, osteo means bone, so only one bone is affected. This accounts for 70 to 80% of cases of fibrous dysplasia. This is the order of favorability of fibrous dysplasia. Ribs have the most predilection, followed by femur, then tibia, then the craniofacial bones and humerus. Pain and pathologic fracture might occur in long bones due to abnormal cancellous bone. It has equal predilection for men and women. The second type is the polyostotic type. This accounts for 20 to 30% of cases of fibrous dysplasia. More than two bones are affected, hence the name polyostotic. Let's see the order of favorability. Femur, followed by tibia, then the pelvis, ribs, skull, facial bones, upper limb, and lower spine. They may be unilateral or bilateral. Pain and pathologic fracture occur. The next and the most important is the shepherd crook deformity. It's a pronounced bowing and angulation of the upper part of the thigh bone, which is the femur. You can see in this radiograph, the femur bows outward resembling a shepherd's crook. Polyostotic is subdivided into two types, Jefferies type and Albright syndrome. Jefferies type consists of polyostotic fibrous dysplasia along with cafe-outlet pigmentation. Albright syndrome has polyostotic fibrous dysplasia, cafe-outlet spots, and endocrine disorders. The last is the craniofacial form. This mainly involves maxilla, frontal, and ethmoid. Rarely, occipital bones are involved. So, when the orbital and periorbital bones get involved, there is hypotension, exophthalmos, blindness, and visual impairment. When the sphenoid and temporal bones get involved, there is hearing loss, tinnitus, which means ringing in the ears, vestibular dysfunction, which leads to improper balance. If cribriform plate of ethmoid bone gets affected, it leads to hypersomnia or excessive sleep. Insomnia is no sleep, hypersomnia is excessive sleep. Okay. Coming to the monoostotic fibrous dysplasia of the jaws. Let's see the clinical features. It is more prevalent in females, or it has almost equal predilection in both men and women. It typically manifests in the first or second decade of life. Its key symptoms include painless swelling of the jaws and marked facial deformity. Coming to the location and extent. It primarily affects the maxilla more than the mandible. In maxilla, this expansion can extend to maxillary sinus and orbit. In mandible, there is expansion of the cortical plates. The posterior region is more affected than the anterior. The lingual region is affected more than the labial. The distinctive feature is the leonatiasis ossia or a lion-like face, which occurs due to facial bone overgrowth. Okay, this is important. Let's get into the histologic features. The histologic features are especially important in oral pathology. The first is the irregular, immature bony trabeculae. These trabeculae are poorly formed and haphazardly arranged, often described as Chinese letter pattern or alphabet soup pattern. They are primarily composed of woven bone, lacking the organized structure of mature lamellar bone. You can see the irregular trabeculae in this picture. The second point is there is absence or minimal osteoblastic rimming. A key distinguishing feature is the lack of distinct layer of osteoblasts or bone forming cells lining the surface of bony trabeculae. This contrasts with other conditions like osteofibrous dysplasia, where osteoblastic rimming is prominent. In fibrous dysplasia, there is no osteoblastic rimming. In osteofibrous dysplasia, there is prominent osteoblastic rimming. This is the differential diagnosis. The third point is you have to describe about the fibrous trauma. The bony trabeculae are embedded within a background of loosely arranged fibrous tissue composed of spindle-shaped fibroblast-like cells. This fibrous trauma can vary in cellularity. The fourth point is the unmineralized bone or osteoid. There may be an excess of osteoid indicating defective mineralization. So you have to mention these 4 points while you are mentioning the histologic features. One is the irregular and immature bony trabeculae, that is your Chinese letter pattern. The second is the absence of osteoblastic rimming. The third is about the fibrous trauma, which contains spindle-shaped fibroblast-like cells. The fourth is the presence of osteoid. Coming to the radiographic features. This is important from oral medicine and radiology point of view. This can even come as a short answer question in your university exams. So you have to mention these radiographic features of fibrous dysplasia under the following headings. One is location, second is periphery, third is internal structure, fourth is effect on adjacent structures, fifth is the effect on adjacent teeth. So these five headings are important. Coming to the location. Fibrous dysplasia is more common in maxilla than the mandible. It is common in the posterior region than the anterior. Lesions in the axial skeleton are more commonly unilateral. But when fibrous dysplasia affects midline bones, single midline bones like mandible, frontal bone, and sphenoid bone, the changes can cross the midline. Fibrous dysplasia are more commonly unilateral, whereas Paget's disease of bone and cherubism are always seen bilaterally in the jaws. This is the differential diagnosis. Unilaterally, you can see fibrous dysplasia. Bilaterally, you can see Paget's disease and cherubism. Coming to the periphery. You have to describe the periphery of the lesion on the radiograph. It is poorly defined with a gradual and broad transition between the dysplastic and normal bone. This is called blending. It is the blending of the fibrous dysplastic bone into the normal trabecular pattern. Coming to the internal structure. Early lesions are more radiolucent. Abnormal trabeculae are found, which are more in number than the actual number of bony trabeculae when in health. These are shorter, thinner, and irregular shaped. This creates a series of classical radiologic patterns. Ground glass appearance, pudy orange or orange peel appearance, cotton wool appearance due to the wispy arrangement of the trabeculae. The fourth is the fingerprint pattern. Effects on the adjacent structures. When a lesion of fibrous dysplasia is small, it may have no effect on the surrounding structures, and this is referred to as subclinical fibrous dysplasia. As the lesion increases in size, bone resorption results. With maintenance of thinned cortex in the mandible, this pattern of arrangement affects the bone more evenly along its length. This is referred to as fusiform enlargement. This pattern of enlargement should be contrasted with the more concentric type of expansion seen with benign tumors. This is another differential diagnosis wherein fusiform enlargement or even enlargement is seen in fibrous dysplasia, whereas concentric pattern of arrangement is seen in benign tumors. Superior displacement of the inferior alveolar canal or mandibular canal is strongly associated with fibrous dysplasia when the epicenter occurs inferior to the canal. Fibrous dysplasia arising in the maxilla can displace the cortical borders of maxillary sinus, reducing the size of the air cavity. The lateral wall of the maxillary sinus is the first to be impacted. The last region of the sinus to be involved is posterior superior border. You have to remember, the first to be affected is the lateral wall, the last to be affected is the posterior superior wall. Coming to the effects on adjacent teeth. Often the bone surrounding the teeth is altered without affecting the dentition, and a distinct lamina dura disappears as the dysplastic bone engages the structure. If the fibrous dysplasia increases the bone density, the PDL space may appear to be narrow. Fibrous dysplasia can displace teeth and interfere with the normal eruption, complicating orthodontic therapy. In rare cases, some root resorption and hypocementosis may also occur. Coming to the diagnosis. Fibrous dysplasia diagnosis primarily involves a combination of imaging tests like CBCT, MRI, various radiographs, bone biopsy, and sometimes genetic testing, depending on the suspected case and extent of disease. Biochemical tests like serum alkaline phosphatase level is increased. The serum alkaline phosphatase level is also increased in hyperparathyroidism and Paget's disease. There is no change in serum calcium level in fibrous dysplasia, while serum calcium levels is affected in hyperparathyroidism. There is also moderate increase in basal metabolic rate or the BMR. Since endocrine glands are affected, the metabolic rate might get altered. Okay. Coming to the treatment. Observation is one. In some cases, if symptoms are mild or absent, the condition may simply be monitored with regular checkups and imaging. Okay. Next is the medication. Bisphosphonates are mostly given. These medications can help strengthen bones, reduce pain, and potentially slow down the progression of the disease. Sarcomatous changes are unusual but have been reported, especially if radiation therapy has been administered. The next treatment method is bracing. Braces can provide support to weakened bones, helping to prevent fractures and potentially improving mobility. Surgical intervention may be necessary for fracture repair, deformity correction to correct bone abnormalities, including those causing scoliosis or limb length discrepancies. Okay. Surgical intervention is also needed for lesion removal to remove symptomatic lesions or those that pose a risk of future problems. This may involve bone grafting to replace the removed bone. I want to make a small note about the cafe outlet pigmentation. Cafe means coffee, late means milk. These spots give a coffee mixed with milk appearance. They are light brown in color. These cafe outlet pigmentation occur in a variety of other conditions, but I will be discussing two important conditions. One is polyostotic fibrous dysplasia and the other is neurofibromatosis. In fibrous dysplasia, these cafe outlet spots occur on the same side of the bony lesion. They are seen ipsilateral to side of bony involvement. Okay. These have irregular margins which resemble the coast of Maine. You can see in this diagram how irregular they occur. The next is neurofibromatosis. In neurofibromatosis, this pigmentation is generalized and have regular margins resembling the coast of California. I also want to add a note on Mazabroth syndrome. This Mazabroth syndrome has two main conditions. Fibrous dysplasia is one of them. It either can be monoostotic or polyostotic type. Mostly polyostotic type is common. It also includes intramuscular myxomas. Myxomatous changes occur in the muscles mainly. Hope I have made these concepts very clear. You can take a screenshot of this. This will make your learning simple and interesting.